So in my practice, I am seeing mostly depression, anxiety, a lot of addictions, the dramatic cluster of personality disorders, which has narcissism, borderline, antisocial, and histrionic. They socially create drama.
Everybody loves this word narcissist.
Narcissistic personality disorder is marked by a lot of grandiosity, a lot of desire for admiration, and a lack of empathy. What happens in borderline personality disorder is that there is a lot of fear of abandonment. There is an instability in terms of self-image, instability in terms of relationships with others.
I looked at your website and you literally have 100 therapies that you work on. I'd like to talk about EMDR. From what I understand, you brought it to India from the UK.
This lady, Dr. Francine Shapiro, was walking by and she saw two objects and her eyes started darting. While she was constantly thinking about something traumatic, she realized that all the emotional charge from that traumatic memory had disappeared. So that is when she decided to start trying it out in a therapeutic model.
And then we have cognitive behavioral hypnotherapy.
We are able to have a framework of the psychotherapy, and at the same time, we're able to make changes at an unconscious level along with changes at a conscious level.
One part of hypnosis is also hypnosis birthing, which is giving birth without anesthesia under hypnosis.
Right.
How do they do it? Dr. Swati Kashyap is one of India's pioneering psychiatrists. She has introduced cutting-edge therapies to the country and built behavioral medicine departments inside major hospitals like Fortis. Today, we're going to break down various mental health issues, deep dive into the most effective therapies, and give you tools to make you calmer, sharper, and more productive. Let's be honest for a second. The secret sauce isn't for everyone. It's for people who want to grow to achieve their potential. So, if that is you, maybe you should subscribe. Dr. Swati Kashyap, hi.
Hi.
You've trained in, I have to read it out, I'm sorry because there's so many things. Psychiatry, family medicine, psychotherapy, hypnotherapy, EMDR, CBT, and addiction studies. It's a lot of things. Most doctors, choose one lane and stay with it. What gap are you trying to close that one discipline by itself could not solve?
So what I have found in mental health as well as medical practice is that there is a lot of fragmentation. And when I'm practicing in a clinic or in an OPD, I would like that I don't have to send a patient who comes to me with a certain problem every time for testing somewhere else, for counseling somewhere else, for a psychotherapy somewhere else, and for a diagnosis somewhere else. So in order to close these gaps, I have trained in all of these fields so that I'm able to give a one-stop solution and a long-term relationship to any patient who comes to me.
That's quite amazing because I've never met anyone who does all these things together. I wanted to ask you in this area, across all these different therapies and modalities that you use and do, is there a single core philosophy that ties it all together?
Absolutely. So all the threads can actually come together and weave a tapestry. And how I would like to say in terms of the philosophy that I believe in is that I would like to be for my patients that doctor that I would like to have if I am on the other side of the table. So I work hard to become that doctor, and I believe I am a work in progress.
You're like a general physician for the mind.
Yeah.
And I know in India, GPs also are a dying breed.
Yes.
Which causes problems as well because you have specialists everywhere.
Yeah.
But a lot of times you want the body to be seen holistically. So in your case, you want the mind to be seen holistically.
That's right.
Very
And the body, because
and the body.
Family medicine is actually there to bridge that gap that is being created with GPs somewhere or the other dwindling in India. So fortunately, we have family medicine developing as a discipline where more and more GPs are getting trained to become family doctors. And people are going straight after their MBBS into post-graduation in family medicine.
What is family medicine?
So, family medicine is a discipline which basically looks at a patient in a very holistic way in the context of their family and their community and tries to treat most of their ailments. So, we need training in different branches of medicine. The whole idea is that we should be able to take care of 70 to 80% of all ailments without needing to refer people.
So like a like a GP.
Like a GP, just a more advanced form of GP.
I see, it's an advanced form of GP.
Yeah.
So I just want to understand a little more, since we're talking about mental health mostly out here. What are the most common things that you are seeing in India?
So in my practice, I am seeing mostly depression, anxiety. I'm seeing a lot of addictions and clinical and subclinical forms of PTSD. Along with that, I'm also seeing personality disorders and personality disorder traits.
Got it. Wow. So should we start with anxiety, because you named a bunch of things?
Sure.
So clinically, what is anxiety? It's the most common thing today to say, especially among young people or among everyone. I have a little bit of anxiety. I have stress. I'm nervous.
Yeah.
What is what, and where does it come to point where we have to see, someone like yourself?
So we have to distinguish between anxiety as a normal human emotion and an anxiety disorder. So let's try and understand. As a normal human emotion, when there is a threat and there is a tendency to feel a fear, and as a result of that, go into a fight or flight response, that emotion is usually anxiety. If we go fully into the fight response, the emotion that comes may be either facing it with confidence or anger. If we go into the flight response, the tendency is to go into pure anxiety. So, in terms of the normal emotion, this is what it is. But when we talk about anxiety disorders or when anxiety becomes a problem, there is a lot of distress, and that distress is not in proportion to the threat or the circumstances. It is blown out of proportion. And on the other hand, there is also significant dysfunction, meaning impairment in day-to-day functioning. So when these two things are added to constant worry, constant fear, then we can say that this is an anxiety disorder.
Can you give me an example for an adult of something which is just like, normal worrying, and something which is anxiety disorder?
So let us say there is this lady, and she tells me that I am really worried about the fact that I have to pack my bags to go to a city nearby.
Right.
And I'm really worried about this. And I'm also so worried because my child has to give an application in the school, and I mean, this is really worrying me out. And I'm also worried because I have to take leave from work, and I'm terribly worried. And if I ask her, so is this something which is a new worry? And she says that, yeah, this is a new worry because I'm going out on a holiday. But last week, the worry was something else. And I ask her before that, well, the worry was something else. She's always having multiple worries. And then I ask her, do you have a tendency to have a free floating anxiety, and something or the other every time is catching on to that? And she tells me yes. So now I'm looking at something called generalized anxiety disorder.
Got it.
On the other hand, if someone says that I'm really worried about my result, and I have given, let's say, the Indian Civil Services exams, and I'm really worried about my result because this is, let's say, my fourth attempt, and I may not have more attempts, that is usually an anxiety which is in proportion to what's actually going on.
And there are different types of anxiety as well.
That's right. So, broadly, anxiety disorders are now classified as generalized anxiety disorder, the one we just talked about. There's separation anxiety disorder. There is social anxiety disorder, which is also called social phobia. There is agoraphobia, which is a fear of technically it's called the fear of the marketplace, but it may be a fear of any place where an escape is difficult in case one has a panic attack. That's called agoraphobia. Apart from that, there is panic disorder, and there are specific phobias. specific phobias like blood injection injury phobia, or
Snakes.
snakes, animals, or natural environment like height, or situational, different kinds of phobias like flight phobia is one of them. So these are the specific phobias.
Got it.
And yes, one more. In children, there is a particular anxiety disorder you don't see so much in adults, which is called selective mutism. So, an atmosphere where a child feels particularly anxious, they will go mute, they will not talk. But in another atmosphere, they will talk very normally. So, that is another anxiety disorder.
All these different anxiety disorders.
That's
Got
right.
it. And how does it, because for an anxiety disorder to happen, it doesn't happen overnight. It's a reinforcing kind of learned process. So is that something that's common with all these disorders, and how does that happen usually to someone?
So, for any kind of anxiety, usually there are a few things. Let's take three of them to understand better. One is that there is some predisposition, which is usually biological. So, it could be a genetic predisposition. So, the brain is already predisposed to anxiety. The second is that there is a threat or a stressor in the environment. And the third, and I would say the most important, is how that threat is evaluated once one goes into the fear and flight or fight response. Now, if that threat is seen as surmountable, one goes into the fight response, faces it, and things are fine. However, if it is assessed as an insurmountable threat, or something that is grossly overwhelming, then the tendency is to go into the flight response,
Right.
in which case one tries to either avoid or escape that particular threat. And that is when it turns into anxiety. What happens is when you actually use avoidance and escape to get rid of that stimulus, that anxiety is reinforced. And the more it is reinforced through that loop, the more it turns into a proper disorder, such as a specific phobia.
Got it. Another disorder that everyone talks about is depression. It's very common
Yes.
now, getting more and more common now. So I wanted to ask you a couple of things. One is that the view that people have about depression is that, oh my God, I'm depressed. The person who's depressed can't get out of the house, lying in bed the whole day. So we all know that version of it, but it's not as simple as that, obviously.
Yes.
There's the depression that is there more common now is a much more subliminal or not so obvious one, which you need time to find out that you're depressed or not versus just low energy or something like that. Could you tell us more about that? Like, how do you diagnose depression? And what is depression exactly?
Right. So depression, again, like anxiety, it can mean an actual human emotion we all go through, in which case it is just an emotion very close to sadness, but one in which one is feeling low and there is a sense of giving up. What happens in major depressive disorder, or let us just call it depression or clinical depression, is that there is this depressed low mood, but it is persistent and pervasive, at least for a period of 2 weeks.
Got it.
Before that, we cannot diagnose it as depression at all.
Got it.
Along with that, there is one more core symptom, and that symptom is that there is a sense of loss of pleasure and interest in life. Along with that, there can be many other symptoms, such as certain cognitive symptoms, like there's a difficulty in decision making, difficulty concentrating, problems with memory. There can be certain bodily symptoms, such as difficulty sleeping or disturbed sleep, again, a decrease in appetite. And apart from that, there can be other things like low energy, easy fatigue. And there are these emotionally, this sense of hopelessness, helplessness, low self worth, self esteem, and low self confidence. Apart from that, there could also be suicidal ideation and suicidality.
So you need to be diagnosed as clinically depressed, you need a bunch of things for a long time.
That is right.
Got it. And can untreated anxiety disorder become clinical depression?
Well, I would like to answer it like this. Both anxiety and depression are low serotonin states or serotonergic states. What it means is both of them have the deficiency of one particular neurotransmitter. However, what happens is that sometimes when the anxiety has not been treated for a long time, we go through a phase where we have been trying to fight, flee, fight, flee, fight, flee, and a time comes when we start giving up. Now, when this happens, we can develop something called a secondary depression. So, of course, the picture would look like a mixed picture of anxiety and depression, but it is not like the regular depression. It is a depression that has come because of or has been fed by an earlier problem, which was the anxiety.
Got it. Another personality disorder that he spoke about was narcissistic personality disorder. It's a great term. Even you're smiling because everybody loves this word narcissist.
Right.
You're a narcissist. He's a narcissist. She's a narcissist. We have some idea of what it means from that Greek chap who used to look at himself in the lake,
Narcissus,
and then
yes.
Narcissus, yes, and then he froze or something like that.
He actually fell in the lake.
He fell in the lake, okay,
and
right.
died.
And he died. Well, that's what you get basically.
Yeah.
So what is narcissistic personality disorder, and how common is it, and how do you stop it? Because it seems to be quite well hidden.
So, narcissistic personality disorder, as the name suggests, is one of the personality disorders. And it is marked by a lot of grandiosity, a lot of desire for admiration, and also a need for admiration, and a lack of empathy. Along with that, these people can be very entitled. They may have a tendency to be very arrogant. They may feel that everybody is envious of them, while actually they may be very envious of other people. And there's also a tendency to have fantasies of unlimited success, unlimited power, ideal love, ultimate beauty, and all that.
Who doesn't have fantasies like that?
So, all of us, I believe, have one or two traits, I guess. But at the same time, they have a tendency to be, because of their lack of empathy, they have a tendency to be very inconsiderate. Another thing is because of their grandiosity and need for admiration, they have an ego which doesn't seem to be in line, or they do not have what are called commensurate achievements. And someone can have this personality disorder, say a 1 in 100. So statistics say in DSM clearly it is said that 0.5 to 1% people can have narcissistic personality disorder. However, when we say narcissism, we may actually mean narcissistic traits. So people can have minor or major narcissistic traits, but for the disorder, you need at least 5 traits out of 9.
Which are the 5? Which are the 9?
So the ones that I just spoke about. So there is the sense of grandiosity, lack of empathy, there is excessive need for admiration, then there's arrogance, these fantasies of unlimited success, power, and a lot of entitlement. And yes, exploitative and interpersonal relationships. That is a very important trait. So they tend to be very exploitative in interpersal relationships.
Because there has to be a strong dysfunctional element to it.
Yes.
Just having some things, I would say I have at least 2-3 of those things. Or I had them.
Right.
But you have to have those heavier ones as well.
You need to have,
right?
And there has to be dysfunction. That's right. It has to be. The other thing is that the person has to be above 18 for diagnosis. And these traits should have been there for a long time because it's a personality disorder. It cannot be that nowadays they're acting like this. So then it's probably not a personality disorder.
So can you give me an example of how to spot one? Because they are also high functioning.
They often are very high functioning because, they need their grandiosity, they need their entitlement, and they have these amazing fantasies of success. So they usually tend to work hard for this success. The problem is that if you look at their interpersonal relationships, those are the places where you will be able to spot it earlier than you're able to spot it in other places because they tend to be exploitative. So there are more problems in interpersonal relationships than in any other areas of life for them.
And what is this narcissistic person or even someone with a narcissistic trait actually feeling beneath all this hoo-ha and grandiosity?
So actually, that's the most interesting part because unlike that grandiose exterior, what they are feeling inside are three problematic emotions, which are very real and very troublesome. One is envy, another is fear, and the third is shame. And these are very real. They are feeling these in a very real manner and suffering from this. And because of that, they are, at the mercy of other people, because the way they look at themselves, they look at their own self image, is how you look at them or how they think you are looking at them. So their self image ends up becoming very, very fragile, and it changes from person to person. And probably that is why there is so much stress on entitlement and grandiosity and need for admiration, because it's your admiration that cultivates their self image for them.
Got it. Um, Other two personality disorder that you spoke about was borderline personality disorder. Let's talk about that for a minute. What is borderline personality disorder?
So, borderline personality disorder and personality traits are fairly common, and it is something that I end up dealing with a lot in my practice. What happens in borderline personality disorder is, although it is from the same cluster, this is called cluster B, or the dramatic cluster of personality disorders, which has narcissism, borderline, antisocial, and histrionic.
Acha, so they all are,
They're all cluster B.
and I can see what you mean. They all are social.
They,
they all are
they're dramatic. They create psychological drama.
Got
They
it.
socially create drama. So, what happens in borderline personality disorder is that there is a lot of fear of abandonment. Apart from that, there is an instability in terms of self image, instability in terms of relationships with others. For example, either we are completely devaluing the other person or we are idealizing the other person. So there's this, polarity there. The other one is that there is instability of mood. So they have a lot of mood swings. They can have self harm behaviors or self harm threats. They can have anger outbursts, fairly common and one of the problematic aspects of the personality disorder. There can be chronic feelings of emptiness. So when we say chronic feelings of emptiness, these are, there's a sense of something lacking all the time in life, or something lacking in myself.
One of the key concepts, let's call it that, in therapy, in mental therapy and all, is self-image,
Right.
which we're going to speak a lot about today.
Yeah.
Can you tell us a little bit more about what does self-image mean? How does it get built up? And what can dysfunction of that look like?
Right. So, self image basically means how I look at myself. That exactly is self image. Now, there are a few important aspects of the self image. One of them is self worth, which is like a global evaluation of what I'm worth. That going down is very problematic. Another one is self efficacy. Now, self efficacy basically depends on what I feel I'm able to do. So, it is more about function. Am I able to function here? Am I not
Right.
able to function here? So, that's self efficacy. Another thing is self esteem, which is about, feeling good about yourself. And finally, there is self confidence, which is self explanatory. It is about how much trust do I have in myself, how much trust do I have in my ability, which is self confidence for self efficacy. So these are some of the words that are important.
Quite similar.
Quite similar, yes.
Got it. Everybody talks about OCD, but there's also OCPD, which is obsessive compulsive personality disorder. Can you tell me the difference between both of them?
So, OCD is a mental health condition. It can sometimes be a condition with a lot of disability, because there are obsessions, there are intrusive thoughts, intrusive images, and there are often compulsions that one feels compelled to do something. One is able to see that there is no sense in doing this, but one feels compelled to do it and repeatedly do it. So, that can be a very difficult situation to be in, and it is a proper disorder, one with considerable disability. OCPD, on the other hand, is a personality disorder which is marked by perfectionism, so much perfectionism that the task completion goes for a toss at times. It is marked by people being workaholics, meaning very, very devoted to their work, wanting everything their way. So they would not delegate the tasks. And if they delegate them, it would only be if they can make sure that the other person would do it exactly their way. They would be miserly in their way of spending, very preoccupied with rules and details and order and organization. They would also have a tendency to not throw away things easily. So they would keep them collected even if they are worn out and useless. And there is also a rigidity and a stubbornness that they have. And another thing is that they may sometimes have OCD along with OCPD. That can happen, but that's not necessary.
But they're quite similar, no?
That is a disorder. This is just a personality. This is just a very controlling kind of personality that wants everything their way. And they're very, very conscientious as well. So having one or two traits of OCPD is actually not bad and can be pretty useful. But if that becomes problematic and if there is dysfunction involved, then that needs to be treated.
Got it. But how do these, from what I'm understanding, Doc, these two things don't seem to be a massive problem like anxiety or depression or something. So do these...
OCD is more problematic than anxiety or depression.
It's more problematic. So can you give me an example in your clinic on how it manifests with different people?
So the problem with OCD, especially the more severe form of OCD, is that a lot of time goes into these obsessions and compulsions. And the level of impairment is such that they're completely unable to do things that they feel very obsessively about, because they know that the moment they start doing it, they will have to do it in a certain way. So someone with a theme in OCD of, let's say, cleanliness and organization can actually have a very dirty room. Why? Because they feel that if I sit and try and organize this room and clean this room up, I would not know when to stop. So it can create a lot of disability in people. People can have actual excoriations and wounds on their hands just because they keep washing their hands repeatedly, or sometimes their body repeatedly when they go for a bath.
Can you give me some examples of like really bad OCDs? Because, for most people, you think OCD, like I said, is a small thing.
Yeah.
You want to keep your slippers all in a row.
Right.
That's what people think. Or, just like they're little ticks.
Yes.
But like you're saying, it's worse than anxiety, which is interesting for me.
It can. And earlier it was counted, both PTSD and OCD were counted among anxiety and related disorders. Now, because the symptomatology is quite different and the treatment modalities are different, they are given distinct categories. Yeah. So maybe, an example would help. There was this person who told me that they missed their entrance exam because for their OCD, they needed to polish their shoe a certain number of times. So they had to polish their shoe a certain number of times. Then they realized that there was a little dust on their shoe. So they again needed to polish it that many number of times. And in the process, they end up missing the bus. And after that, they tried to go taking a taxi. They reached late. They were unable to give the exam and they flunked the exam. So that is one example. Now, when I asked this person that this is something that happened very often, and they said yes, for a lot of things. They had to sometimes repeat exams. They had to sometimes let go of relationships. And sometimes they would have to buy things over and over again because the OCD demanded that. So they would buy, they would find that, this wasn't clean enough. They would try and clean it, destroy it, throw it. We'll need to buy it again. So that sort of thing can happen. Although most OCD themes are generally about, germs and cleanliness or about order, but they can be different types. There can be different themes in OCD. One particular theme, which you would find quite problematic if you meet someone with that, is constant reassurance seeking. So they would ask you, okay, is this fine? Then after some time, they would ask you the same thing. Then again, they would ask you the same thing. And then they would ask you the same thing in a roundabout manner. And they would keep, finding you just to ask you the same thing over hours and sometimes over days.
Got it. Okay, small pause. This is the part where I'm supposed to ask you to subscribe. But honestly, only do it if you want more conversations that actually make you think. That's the whole point of the secret sauce. All right, back to it. One of the areas that you work in, Doc, along with being a GP and all the mental health things that you're doing that we spoke about, is behavioral medicine. Can you just explain what is behavioral medicine?
So, behavioral medicine, which is a sister branch of psychiatry, you can think of it as an overarching field that is made of different modalities of therapies, such as medical hypnotherapy or mindfulness based therapies or biofeedback or eye movement desensitization and reprocessing, pain reprocessing therapy, and many other such therapies, along with certain psychotherapies as well.
Got it. But so these are all types of behavioral medicine, I guess. So how is this different from traditional psychotherapy?
So, behavioral medicine can be defined as an overarching field which basically takes techniques, various psychotherapies, and other mind body techniques like medical hypnotherapy, EMDR, which is eye movement desensitization and reprocessing, mindfulness based therapies, and uses them to treat mind body ailments. Now, these can include some of the psychiatric ailments, these can include some of the medical ailments. But these are a group of techniques that are particularly amenable to treatment of ailments like chronic pains. Another one, a new addition, is pain reprocessing therapy, which works very well, and certain other therapies like medical hypnotherapy also works very well for chronic pain. Then, for various psychosomatic illnesses like acid peptic disease, sometimes even blood pressure to quite an extent, especially when it is early blood pressure. Then, for certain anxieties, for certain childhood problems like bedwetting and stuttering, stammering, and for childbirth, pain free childbirth, IBS, various other psychosomatic illnesses that we know have a mind body connection and need to be tackled in a mind body way for the connection to break and basically for both aspects to be treated.
Got it. You were building in Fortis Hospital in Delhi and Kailash Hospital in Delhi. You were in charge of building the behavioral departments. What were the common complaints that people walked in with?
So, in Kailash Hospital, the common complaints that I saw in my department were chronic pains, obesity, IBS, acid peptic disease, sometimes people with allergies, sometimes children with certain problems like dyslexia, ADHD. Another group of patients that I regularly saw in these hospitals was patients who had various addictions. And we saw a lot of alcoholism and a lot of smoking. And because medical hypnotherapy works very well with smoking, we were able to treat a lot of patients for smoking. With alcohol, I realized that the problem is much more multifactorial. So that was probably one reason why I took further training in other addiction therapies. And with the knowledge that I had at that time, I used my knowledge of addictionology and behavioral medicine to treat many of these patients who were highly committed to treatment.
Because I know what you mean. Alcoholics are very often depressed also. But a chain smoker is not depressed. They're just chain smokers, basically.
Yes.
And
Right.
what is an addictionologist?
So, an addictionologist is a doctor who has a special interest in working with addictions. Now, they may have, like myself, a diploma in drugs and alcohol studies, or they may have done a residency in addictionology, or they may just be psychiatrists who have worked specifically with addiction patients for a long time.
And what do you think are the most common types of addictions that you see nowadays?
The most common, apart from alcohol, because that's always the big one, is cannabis and also stimulants. So not just cocaine, but other stimulants like amphetamines, MDMA, and others.
Really, you see people who are addicted to
Yeah,
amphetamines,
yeah.
MDMA.
MDMA, which people think is just a party drug. There's so many people who are genuinely addicted to
But
that.
how much do they have every day or every week?
They start having these pills very regularly, and it starts going up, and they start having it not just at parties. They start having it regularly without like what is called in a closet way. They start having it.
Like every day.
Yeah, every day. They can't stay without it.
Every day. So you
Every
have some
day.
patients who have a MDMA tablet every day.
Yes.
For how long can they have it every day?
For a pretty long time, till they have a terrible side effect or they actually decide to clean up their act.
Like a year?
More?
They have an MDMA pill every day for a year.
Yeah.
Wow. I want to talk to you about the different therapies. I looked at your website and you literally have 100 therapies that you work on and you use. For today, we'll just look at a few therapies that we discussed, and you can tell us a little bit about them. The first one was cognitive behavioral therapy, or CBT.
So, cognitive behavioral therapy. Now, cognitive means thoughts. Behavior, as you know, means behavior. So, this is a therapy where you are actually looking at dealing with the thoughts on one hand, dealing with the behaviors on the other, in order to improve the third aspect of an internal experience, which is a person's emotional state or mood.
Got it.
So, let us say someone has depression. We can use cognitive therapy on one hand, dealing with their thoughts, trying to find if there are any errors or any, let's say, distortions in their thinking and correcting those distortions. On the other hand, we can look at certain behavioral exercises that would increase their activity level, for example, because in depression there is a tendency to have less activity or your routines going bad. So we would do both these things, and when we do both of these in a two-pronged way, it actually helps improve their emotional state or their mood state of depression.
Oh, I see. So that's what cognitive behavioral is.
Yeah.
It's brain and physicality in a way coming together.
It is thought and behavior coming together.
Got it. And what is CBT good for?
So CBT is great for depression, it's great for phobias, and it's great for OCD. It has a decent use in addictions.
Can you give me an example of how what do you do in CBT?
So the first thing is we start with the cognitive therapy. So we talk to the person and we make a model. We use pen and paper and make a model. And that model basically is called hot crossed bun.
Oh,
So there is thoughts on one side, emotion on the other side, there's behavior on one side, and physical sensation on the fourth side. And all of these are interacting with each other. So both of the sets are in every possible way influencing the other three. All of them are influencing. Each one of
Thoughts?
them is influencing the other three. Thoughts, behaviors, physical sensations, and emotions.
that's our whole life.
Yeah. So that would be an example of how we begin the cognitive therapy
So you make
in
a map
depression. Yes.
showing how a thought can influence a behavior, or a behavior,
behavior
can influence an
a
emotion,
thought.
vice
Yes.
versa.
Yes.
Got it.
Because directly accessing emotions and physical sensations is not possible.
Mhm.
The easiest to change is a behavior. The second easiest, but a little challenging to change, is the cognition or the thought.
Got it.
So with those, we are able to change the emotional state as well as the physical sensation.
Got it. So it's the gateway into that.
That's right.
Got it. And then after CBT, we have cognitive behavioral hypnotherapy.
Right.
What is that? Sounds very similar, but obviously it's not.
So cognitive behavioral hypnotherapy combines two types of therapies. Traditionally, it combines rational emotive behavior therapy, which is the mother of CBT. But nowadays, we combine CBT as well with hypnotherapy. So when we combine both of these, we are able to have a framework of the psychotherapy, and we go according to that framework. And at the same time, we are able to make changes at an unconscious level along with changes at a conscious level. So much better, deeper changes can be made.
With hypnotherapy, I've done it many times. The first time I did, obviously, everybody gets scared. Oh my God, what will happen? And all these silly questions. What if they say something, put something into my head, and of course, I've done it many times. So there's nothing, nobody's putting anything into your head. In a simple way for laymen, can you just explain what is medical hypnotherapy?
Hypnotherapy is doing therapeutic work in the state of hypnosis. Now, what is the state of hypnosis? Actually, it means the state of sleep. But hypnosis is a little different from sleep. It is almost like a semi waking sleep. Your conscious mind, which is active in the awake state, and the unconscious is asleep. And in the sleeping state, the unconscious starts becoming active randomly, and the conscious is sleeping. In this particular state, you have part of your conscious mind active and your unconscious beginning to become active, literally layer by layer. So you're able to, in a very systematic way, go into your unconscious through your conscious mind. And therefore, nobody can actually plant any suggestions in hypnosis without us giving them consent, while in real time also. Because the moment they say something which we are not okay with, we would reject it even then.
And why is it's so important to access the unconscious?
Perhaps because all habits end up sitting in the unconscious. All the things that we do on an autopilot are actually having a proper plan, but that plan has gone from conscious to unconscious mind. So if we were trying to change something, trying to change a belief or trying to change a behavior or a pattern, we literally have to go there, access it, and then make the changes. If we are trying to plant something new, we have to go deep and plant it there so that we don't have to keep repeating it, say 100 times before it actually seeps into the unconscious.
But there's so many different people who practice hypnotherapy. Some of them say you come once and you're done. You can quit smoking in one shot or anything, quit anxiety, phobias. Some say, keep hearing the thing 100 times. What is the answer? Because there's so many different versions of hypnotherapy.
So I would say when I was training in the London College, it was particularly famous for its results in smoking cessation. So I usually follow their script, which says about 5 sessions is what it requires. And I almost verbatim follow their script, add a few things from mindfulness based therapies and CBT to make it a better program, and also sometimes offer my patients medication for stopping smoking along with that.
One part of hypnosis is also hypnosis birthing,
Right.
which is giving birth without anesthesia under hypnosis.
Right.
You were actually brought into Fortis Hospital for hypnosis birthing. So I just want to understand, why would someone want it or need it, and how do they do it?
So, hypnosis birthing is actually one of the birthing programs, but more importantly, it is a program where we can use a hypnoanesthesia technique to anesthetize oneself while one can still feel the contractions. So, the reason why people would like to do it is people would like to avoid painkillers, which have become quite common at the time of birthing. And people would like to hasten the process of labor because it has been found through multiple studies that it can actually hasten the process of labor by just bringing nature back, meaning letting the woman step out of the fear response and bring the balance of the body back. And the body knows what to do, and the body would not take that long to do it. And hypnosis birthing has definitely helped people, according to major research studies, including the systematic reviews, in decreasing the need for analgesics or painkillers. It has also led to a much better subjective experience. For example, the British princess went for hypnosis birthing during her birthing process and had some wonderful things to say about her
Princess
experience. Princess Kate.
Is it because a woman, she's scared of the anesthesia, or is she scared of the childbirth, or why would someone opt for that?
So, one of the reasons for opting for that is that there is this cultural programming that women have, which is that childbirth is going to be so bad. It's the worst pain that you can go through. There's so much fear around it that unfortunately that becomes a self-fulfilling prophecy.
So then you have to take the anesthesia,
Then you
that
have to take the
epidural.
anesthesia, the epidural, and along with that, sometimes or before that, sometimes even painkillers. Whereas what you do through the hypnosis birthing program is, apart from the hypno anesthesia, you also train yourself for not being in that fear response. So it is making that process in our mind more natural, more self-limiting and self-containing, which I believe sets the stage right for the hypno anesthesia to work.
Got it. So it reduces fear and makes for a more positive and shorter birthing experience.
That's right.
And natural
And
birthing experience.
usually natural.
Got it.
So I remember I was called a few times in Fortis to the labor room, and I was told that this particular lady is unwilling to go for cesarean section, and there is prolonged and arrested labor, and
So it's
she's
an
completely
emergency.
yes, she's completely unwilling. Do you think you can try something with your hypno anesthesia and hypnosis birthing? And I told them, as first and foremost a medical doctor, that we can only give it a trial till the safe period allows. Like, we cannot just go on waiting. And almost in every case, to my own surprise, it's almost like the body knew what to do. All I had to do was give the right suggestions, induce hypnosis, give affirmations to, feel more confident, more trusting, and then gradually induce the hypno anesthesia.
But
And
this
in
was,
almost,
they called you this at the time when the woman was there. So it was an emergency.
it was not only an emergency. I had never seen these women. They had no idea
So at that
what
point,
hypnosis birthing was. They were just told that you want to try this. And they said anything except epidural, anything except
C-section.
C-section.
And how much does the pain reduce with hypno anesthesia?
So depending on the level of training. So if they have trained well for over 6 weeks, at least 6 weeks, over 6 weeks would be ideal, the pain significantly reduces. For example, there was this one of my first patients, and again, she was from another country. And a gynecologist was very surprised because she said this was the first time I actually saw a no noise birth. Like, not even like nothing. It was like a no noise birth. And it was like she was on the top of things. And it was almost like I was there to assist her, but she sort of birthed herself. So,
Wow.
depending on how much practice someone has had, the anesthesia can work, to different degrees. I wouldn't say it would be absolutely pain-free. That would be a lie, at least from what I have seen. But pretty pain-free, pretty enjoyable. Apart from, of course, the contractions, that's a new feeling. One has to get used to the feeling. And looking at the contractions not as pains, but as just what they are, contractions.
I see. And statistically, this is safe. There's no problems with it.
Yeah, that's the best thing, that there is no downside as such.
There is no downside, right?
Yeah.
Because you're going to deliver naturally anyway.
Yes.
You may have a lot of pain, or you may not have a lot of pain. You may hate your hypnotherapist, or you may not hate your hypnotherapist. That's the downside.
I have had a few patients who knew that they have to go for the cesarean section, but they still went for hypnosis birthing. And when I asked them that, why do you want to do it? Because yes, there are other benefits, even in a C-section, even in a planned C-section, there are other benefits. But they said that they wanted to do it for the program and to generally feel on top of things and not feel like a passive person in their own body, not knowing what is going to be done to them, and then suddenly waking up with a scar and a baby.
Yeah. You also practice pain reprocessing therapy,
Yes.
which is a mental technique for chronic pain.
That's right. So this is a relatively new technique, and the evidence base is growing. And I did the training recently from the US. Here, what we do is we look at chronic pain as an entity which has a huge psychological overlay or a psychological dimension. So we are looking at the anxiety around that pain, that anticipation that we have, anticipatory anxiety around that pain, the restrictions, which is basically behavioral, the restrictions that we are imposing on ourselves because we have that pain. And we are using a lot of psychoeducation and relaxation techniques to finally bring that pain down to a level where it is very manageable. So, just to explain, all chronic pain has three aspects. One is the actual biological aspect, one is the suffering aspect, which is mostly psychological. And another one is a neurological aspect, which is the same neurons start firing, the same nerves start firing, even when there is no new trauma. So they start firing and they keep looping. For example, in arthritis, there's an actual biological aspect there. Then there is the looping of the nerves, which keep firing and keep sending us pain signals. And then there is that psychological overlay, which says that, oh, this is so terrible. Like, I mean, my knee doesn't function
You're
anymore.
focusing on it.
And I'm so restricted because of this. I can't do this and I can't do that. And I mean, what will happen? So the other two can be taken care of with pain reprocessing therapy.
I'd like to talk about EMDR, which is eye movement desensitization and reprocessing, which I've tried with you as well. And it involves moving your eyes very fast. Firstly, I want to know that, from what I understand, you brought it to India from the UK. Can you tell us about why you brought it to India and what is it and what is it good for?
So while I was training in the UK, I got to know from my teachers there that some of their colleagues had been flown into India to go and do EMDR for trauma survivors after the tsunami. So I was naturally very interested. I tried to find out what this was, and they said that this is a new therapy which is for post-traumatic stress disorder. And because there was a lot of post-traumatic stress disorder in India at the time and no therapist who was doing it, so therapists were flown in from the UK to India. When I got to know this, I decided that whenever I go back, I will make sure that I do all the levels of training in EMDR. So for an EMDR clinician, there are 3 levels of training. So I made sure that I completed all of those, had a decent amount of experience in working with trauma before I actually came to India.
And when was this therapy invented?
So, well, there's a very interesting story of its discovery. This lady, Dr. Francine Shapiro, was walking by and she saw 2 objects and her eyes started darting while she was constantly thinking about something traumatic. As she kept doing that for a while, she realized that all the emotional charge from that traumatic memory had disappeared. She tried to access it again, it had disappeared for good. So that is when she decided to start trying it out in a therapeutic model, whether she could reproduce what has actually happened, what had actually happened with her. So that is the story. And this was in 1987 when this actually became a therapy. For all therapies to become popular, to become fully standardized, it takes a decade, 2 decades.
Right.
So this was in the early 2000s that I got to learn EMDR.
So it's based on basically moving your eyes and thinking of the trauma, and then the trauma, the emotional connect goes basically.
Right. So what happens is the hypothesis is something like this. They say that all the traumatic memories, like mini traumatic memories that we collect in a day, they get processed when there is REM movement, which is rapid eye movement during our sleep. Now,
And when you say get
there is
processed, what do you mean?
processed meaning that the emotional charge is discharged.
Ah.
And then it's just a mental record that this happened, I was upset, but I'm not upset now when I think
So
about
like
it.
when you wake up the next day, you feel it's gone.
It's almost gone.
So just to be clear, the mini traumas that we have in a day, the mini traumas, not the big ones, while sleeping, by us moving our eyes, crazy, these are all crazy things. By our moving eyes, they get processed and then chucked out as waste, kind of. They
That's
go into
right.
the waste paper basket of our brain and they're out. And we wake up the next day not thinking, oh, this little thing happened to me.
Yeah.
Someone said this to me. You get up fresh.
Yeah.
Got it.
So sometimes it may take several nights to sleep over a trauma and for all of the charge to be discharged. But what happens with major traumas or repeated moderate traumas is that we feel so overwhelmed by it that the mind decides to literally make a metaphorical capsule and leave it there. So the
A
mind cannot
storage
be
box,
yeah,
like
yeah,
like a file cabinet.
yeah, like a file in the mind where it's closed, it's locked.
So the emotion and the memory of a strong trauma gets kind of solidified
And locked.
and locked in some part of our brain,
That's right.
right? Where it keeps coming back and replaying.
Where it keeps, on one hand, very surreptitiously leaking and creating problems for us, sometimes feeding addictions, sometimes feeding other problematic behaviors.
Causing dysregulation in the nervous system in the
That's
brain.
right. And on the other hand, every time it is touched, every time it is brought back, it comes with the original force. By force, I mean the emotional force, the lucidity. All of it is as if it is ready to happen all over again, right now, in the here and now.
Right.
And that is also how let's say the pathogenesis of PTSD
yes.
also takes place,
Yeah.
right?
You
Something
relive
is
it.
just
You relive that horrible incident again and again and again and keep re-traumatizing yourself, and the cycle goes on and on.
absolutely.
And then it causes a lot of dysregulation in your entire system.
Yeah. So now we bring the memory back in a very contained, safe environment with a therapist. That is why EMDR definitely is a therapy that even I would not do on myself, even if I have done, say, hundreds of EMDR sessions. We need to have a properly qualified therapist with us to keep us safe and bring the trauma back, and then use eye movements. And there are other things that one can use, like alternate shoulder tapping or alternate knee tapping, especially this one, the knee tapping we do for children. And while holding that trauma in our mind and letting new connections being made while we are doing this alternate stimulation. And what is found is that once we have processed a particular memory, it loses its charge, not just in that session, but for good.
Right.
It doesn't come back.
So has this worked very well for all PTSDs?
It does. In fact, it is the first line therapy recommended according to international guidelines, whether it is NICE guidelines in the UK or WHO guidelines, because it is a very, very effective therapy. So even though it was discovered in a serendipitous manner, it has turned out to be a real
Wow.
discovery in mental health.
That's amazing.
Yeah.
Another therapy which I find very interesting is the emotional freedom technique, which is basically tapping yourself. That seems such a simple thing, but it seems to work like a miracle, and you can do it yourself. Can you tell us more about that?
Yeah. So when I was recommended by my colleagues who were doing trauma work that try learning EFT, I was a little skeptical because, at that time the evidence base was building. Well, it is still building. And I found to this date that as a self help tool, it is one of the best that one can do to get rid of problematic emotions almost within a few minutes.
Because it's so simple and beautiful. If you don't mind, can you take us through a session of that?
So maybe just one round,
Yeah,
because
one
a
round.
session would take
No, one
long.
round, yes.
So as a self-help tool, I would just tune into the irritation, and I would try to see on a scale of 0 to 10 where it is. And then I would just do the basic version of EFT, which is I deeply and completely love and accept myself. I deeply and completely love and accept myself. I deeply and completely love and accept myself. So 3 times here on the karate chop point. After that, on the head once, I deeply and completely love and accept myself. Then eyebrow, I deeply and completely love and accept myself. Side of eye, I deeply and completely love and accept myself. Below the eye, I deeply and completely love and accept myself. Below the nose, I deeply and completely love and accept myself. Below the lower lip, I deeply and completely love and accept myself. Below the collarbone, I deeply and completely love and accept myself. Below the axilla, I deeply and completely love and accept myself. Again, karate chop, I deeply and completely love and accept myself. So that is one round. And I keep doing rounds till that
You see,
four becomes
I
a
feel
zero.
calmer.
Yeah.
I don't know if you can tell, but
Yes.
I felt my breathing go down just with one round.
Right.
I felt calm, and you do it 7 times,
Yeah. So I recommend 7 rounds on a daily basis.
twice a
Um,
day.
If possible, twice a day, yes. But generally, when it is for something specific, the rounds would be decided by how soon that 4 or 5 or 9 or 10 becomes zero.
Right. Yeah. See, I'm already talking slow with just one round. I really think that technique is amazing because everybody can do it, and it takes
Right.
2 minutes to do.
Yes.
So you focus on that emotion, feel it in your body,
Right.
and then you just do this.
You keep tapping till it goes away and becomes a zero.
And what I also love about it is because you're saying, I deeply and completely love and accept myself. So when I started doing it, I found that very interesting because you do realize that all the emotions you feel, even though you're blaming this and you're blaming that and situations and all those are all judgments, but the deeper judgment is to yourself. So
That's right.
if you really accept yourself, then you accept everything around you.
Absolutely.
You accept what's happening to you. You accept your situation.
Yeah.
And then you're pretty much okay
Yes.
with the vicissitudes of life, basically. I really love this technique, yeah. And I
love
recommend
it
it to
too.
everyone. Yeah, it's just so good, yeah. You know, we're talking about it for emotional things. I heard it really helps a lot for weight loss as well. Is that true? Does EFT really help for weight loss?
So EFT specifically for weight loss, from what I know, does not help, but indirectly it can really help for weight loss. And that is in people who have specific food cravings. Because EFT is almost an instant fix for a craving. The only problem is we usually don't allow EFT to come between the craving and our eating what we are craving. So if
Right.
we do, it's almost an instant fix. So what happens is that as we do EFT on our craving, before we have a food that we should not be having, say, if we are trying to lose some weight, the taste of the food changes and our desire to have that food changes. In fact, one of my colleagues who had done it for bread almost vomited when he was offered bread and he tried to have it. He almost vomited, he gagged
Oh.
right after the technique
So
while I was learning it.
So if you want to lose weight, you're saying focus on that feeling of desire and hunger that you have for
desire
that
and
food,
hunger. That's it.
and practice EFT,
And practice EFT on that.
and you'll accept yourself and love yourself, and then you won't feel that
Yeah.
emotional need for eating.
Right. And somehow the taste or the desire just goes. In that moment it goes. Of course we can reinfect ourselves, but in that moment
Got
it
it.
goes.
Yeah, it's for that moment kind of thing. In the long run, of course, you get better and better.
So I use it for craving for my patients who are struggling with addictions, because it really helps them when they are in an environment. Let's say someone has alcoholism and they have left alcohol, but they're going to be in an environment which happens quite often. So I just request them to excuse themselves, go to the washroom, just do a few rounds of EFT till the craving comes down.
Wow.
And then perhaps, wind up everything and then maybe just excuse themselves
Right.
permanently from that atmosphere.
And find some new friends.
So, yes.
But that's amazing. Yeah, so you can use it for food. That's a new one, right? I have a massive sweet tooth. So I'm going to try when I'm having my 3rd scoop of ice cream.
Right. Just before that, you can do it.
Maybe before the 2nd.
Okay.
Not before the 1st. But yeah. And Doc, today we spoke a lot about disorders, negative things, and how therapies can help make negative things better, erase negative things. But what about making neutral things positive? Like, what about productivity and performance enhancing, because
Right.
that's as important today. You know, everybody wants to be more productive, more live a more fulfilled, content, happy life. It's not that they are petrified of something or they have some deep addiction,
Hmm.
but usually you don't think of going to a therapist until you have some serious problem.
Hmm.
What do you think you can do about that? Like how do, like this EFT? I like EFT very much because that's why I wanted you to do it, because I believe everyone can benefit from it.
Right.
So what are the other things that people can do to just make themselves, happier, better lives, either with a therapist or by themselves?
So, I would like to answer this question by first explaining the difference between therapy and life coaching. So, traditionally, therapy means solving problems and coming to a neutral, healthy state. And coaching means developing a positive quality or new efficacy in a certain area. Uh, One of the things that I trained in was neurolinguistic programming. So, what we can do with neurolinguistic programming is that we can use it as a very structured, very formal life coaching tool to help ourselves in many of these areas without needing to go into proper therapy. Another aspect is that at some point or the other, all of us as human beings do need therapy. And that is where we probably need to come out of that shell, which somewhere or the other makes us feel that, oh, if I need therapy, then obviously there's something wrong with me. So I guess, one, we have to have a change there. And two, we have to also look at life coaching as a way of improving in certain areas.
So what could someone do by themselves? Like after watching this podcast?
So, I would like to share a very simple and well known technique for stress management in the moment. It's called box breathing. So, what we do is we close our eyes, and when we are inhaling, we imagine that we are going up one side of the square. Then we hold the breath and we are going at the top of the square towards the other side. Then we exhale, we are coming down the other side of the square. And then we wait, we are going back to the first side. We continue doing this for some time, and we find that after some time, things change.
Like 3 second kind of hold kind of thing.
So let your inhalation, for example, set the pace. Whatever time you take for the inhalation, take the same time for the pause, take the same time for the exhalation, take the same time for the pause after exhalation. But just doing that is one aspect. It's a physiological aspect of setting the breath. When we add visualization to it, automatically, the moment we focus on our breath, we start going into a trance or hypnotic state. The moment you add visualization to it, you have actually gone there and you are doing something there. You're actually like following something.
So you're saying it's important to visualize the box as well, not just do the breathing.
Yes.
I've been doing the breathing, but not visualizing.
The visualization, yes, that is very important because the breathing will take you into a hypnotic state. The visualization will make you do actual hypnotic work. And by the time you come out of it, you definitely feel calm.
And how many? 10 reps?
About 15 would be great.
Right.
Or more. I mean, the more the better,
The
but
more the
15 to 25 would be good.
Got it. Great. Another therapy or training that you talk about, which I haven't done yet and I'm looking forward to do, is mindfulness based training. So you want to share some technique in that?
Sure. So it is basically a medically studied and standardized form of, let's say, a Zen Buddhist technique, and actually a technique that has its older roots in ancient yoga. So, what we can do here is a 3-minute breathing space. So, I will just do the breathing space and you can follow. So, allow your eyes to close and let your head, neck, and spine be in a fairly straight line. Make sure that there is no intertwining of your fingers or crossing of your limbs. Now ask yourself, what exactly am I experiencing right now in this moment? First, in terms of thoughts, what thoughts am I thinking? There's no good or bad thought. It is what it is. Just take a note. Now, what emotions am I feeling right now? Try and name the emotion. Don't develop a like or a dislike for any emotion. Stay as objective as possible. And if there is no emotion, just make a note of that. And finally, what am I experiencing in terms of physical sensations? So, focusing on different body areas, looking for any aches or pains, looking for areas where we feel cooler, others where we feel warmer, looking for areas which are feeling a little more crushed because they're supporting the weight of a particular body part, and others that are feeling lighter. And now, imagine that we gather all our experience of this moment, our thoughts, our emotions, and our physical sensations, and put all of them in our trunk, and leaving them there, bring our entire awareness only to our breathing. Breathing in and breathing out mindfully. Focusing on the nose, breathing. Focusing on the shoulders going up and down with every breath. Focusing on the chest, inflating and deflating. Focusing on the abdomen, slightly inflating when we breathe in and slightly deflating when we breathe out. Now, along with these parts, let us begin to expand our awareness right up to the edge of our skin, including all the body parts, whole of our body, the way our limbs are placed in space right now, our posture, our facial expressions. And when we are ready, let us gradually come back to the here and now, softly opening our eyes. So, this is probably the shortest mindfulness exercise. And what it does is that it changes what or how we have been feeling right before the exercise. It's almost like, when in the kitchen, someone is making a pudding and there is a layer of cream on top of the pudding. You don't keep taking that layer out. All you do is you let that layer go in, and a fresh layer comes on top of it, and that layer gets dissolved by itself. So, that is exactly what we are doing to our experience and our awareness in the moment through this exercise.
You're letting it get absorbed.
You let it go inside, bring a fresh one on top, and this one gradually gets absorbed.
Very nice. Thank you so much, Doc. Really enjoyed it and lots to learn. Thank you.
Thank you.